I'm Deborah Kahn, founder of Being Patient. Today, we're going to talk about longevity. It's a topic all of us want. We want to live longer, but we also want to live healthier. Instead of the stereotype of getting older and getting a terminal disease. So with me, we have Dr. Dobri Kiprov. He is a longevity specialist who is studying a technique of plasma exchange. And we're going to go into that a little bit later. But his work is fascinating and also is having an impact on people who have been diagnosed with Alzheimer's disease. Dobri, thank you so much for joining us.
My pleasure.
Okay, let's just start very simply and say people are living a lot longer. We know that. It seems quite normal to live into your 90s today. Are people living healthier lives or are they not?
They're not. Unfortunately, they're not. People are living longer, but the later part of their lives are usually miserable. They suffer from a variety of diseases. Um, Almost all of these diseases are related to chronic inflammation. Alzheimer's is one of those diseases, but it's not limited to that. It involves the cardiovascular system, so people suffer from heart attacks, strokes, diabetes, and so forth. So the last 10 or 20 years of most people are spent with many physicians, on many medications, in hospitals, on wheelchairs, so forth. And that's not a life that one wants.
Okay, so can you tell me, I mean, we know with diseases like Alzheimer's, the pathology is like beta amyloid plaque, tau tangles, and then inflammation. And I have been told when you reach an inflammatory state is when you're usually seeing symptoms, right? You're experiencing the symptoms of Alzheimer's. Is inflammation the root of all evil to many of these diseases?
Pretty much so, yeah. Most of these diseases are due to chronic inflammation, and attacking chronic inflammation in our medical approach to aging and these diseases is essential.
Okay, so what exactly does inflammation mean? So, for example, when we think of inflammation, we think of swelling or you get a bruise and a bump. When you're talking about the brain, for example, what does that mean to have inflammation in the brain? What's happening?
So there are two kinds of inflammation. One is good, the other one is bad. Uh, Inflammation is a defense mechanism by the body to prevent us from infections, uh, cancer, and variety of other things. Everything that the body recognizes as foreign will be attacked by the immune system. And usually this happens through acute inflammation. So if you get infected with a flu virus, there is a curve that you get, you start sneezing and coughing and all that, and it reaches a nadir, and then from there on, over several days, it goes away, and you forgot about it. And this is acute inflammation, and this is a normal response that prevents us or cures us of infections and so forth. The chronic inflammation can be triggered by acute inflammation, which does not go away because of some sort of a defect or disease of the immune system that does not allow us to get back to normal, from acute inflammation to normal, which is no inflammation. But there is always a certain remnant of inflammation. And we call this chronic inflammation. So chronic inflammation can be induced by acute inflammation that got a little array, but also it can be caused by continuous insults by either trauma or cancer or some other disease that causes inflammation continuously, and the body is not capable of getting back to normal. The inflammation continues. As we age, all these components of the immune system that circulate in the blood get somewhat overwhelmed over time. So we accumulate a lot of inflammatory factors, proteins usually, that circulate in the blood, and the body is not capable anymore to get rid of them. And older people suffer of chronic inflammation much more frequently than younger people.
Would an autoimmune disease be an example of this chronic inflammation?
Correct.
So basically, your body is producing or holding on to bad proteins, which could be harmful to and feed chronic diseases. Is that correct in layman's
Very,
terms?
very much so.
Okay, so what I'm interested in is I find your research on plasma fascinating. And I think we should start with the mouse study that inspired you to take on this research. Tell us first what was discovered in mice that you later thought should be carried forward and tested in humans.
The original experiment was called parabiosis. It is an animal model that combines the circulation of two genetically identical animals. In this case, was mice. And what the Comboys, this was done by the team of Irina and Michael Comboy and their colleagues at Stanford University at that time. What they did in order to study aging, they combined the circulation of two mice. One of the mice was young and the other one was old. So what they observed was that the younger mouse became older and the older mouse became younger. So most people forgot the fact that the young mouse became older. They were interested in the older mouse becoming younger. And the natural assumption right away was that there's something in the blood that's rejuvenating, some molecule. We always are looking for a silver bullet, the fountain of life. And people decided that, human plasma from young people is the fountain of life. Uh, this is much more complicated than that. To tell you the truth, this was 2005, now it's 25, so 20 years later, there have been millions and millions and millions of dollars spent to find out what is the silver bullet in the young plasma. And despite the fact that many very accomplished scientists have been involved in this field, nothing has been found. So it is not that easy of an answer to that. However, in the meantime, we found quite a few factors in the old blood that cause the inflammation and the aging of the young mouse.
So the bad proteins are what you're
Correct. So the bad proteins, we have identified quite a few of them. So we know that, but we didn't find the rejuvenation ones yet. Maybe they exist, but I'm telling you, there are a lot of pharmaceutical companies that would love to have the silver bullet and make a pill and we live forever. So in my opinion, this will never happen, but that's my opinion.
So, okay, so the mice, I mean, it was actually really interesting what you did to the mice, or not you, the experiment, the scientists did to the guys. They actually bonded them together so that they shared circulatory systems, which basically their bloods, like the blood of each mouse was circulating among the other. So when through that experiment, the younger one, when you said it took on older and the older took on younger, did one of them suddenly become diseased and the other one was healthier with disease? What did that look like in the mouse study?
Well, interestingly enough, in animals, we are able to do autopsies and find out exactly what happened in different organs. And the Comboys did morphologic studies, which I have seen, and they documented morphologic changes in different organs. In the liver, for example, they documented increase in fibrosis, decrease in fibrosis in the older mouse. So in the brain, they found that there are neurologic changes, morphologic, that happened in both the younger and the older mouse. So they were able to document that, and also did physiologic studies in the blood that showed significant changes. So basically, what happened, according to them, and I agree with that assessment, is that they were able, by combining the two circulations, they were able to change the environment in the body where all the other cells live, from stem cells to neurons. All cells live in the environment of the blood, and predominantly the plasma, because that's where the proteins are and so forth. So changing the environment from old to young, we call that the milieu. It is essential for rejuvenation and continuation of normal cell proliferation.
Okay, so tell us about the research that you've done with people who have had Alzheimer's disease. You may, if you want to share some slides, I've enabled sharing, but I think this is fascinating, and I have so many questions about this. But tell us what you did. I think there were several hundred patients, 400 or so involved, right?
Correct. So this is a study that was initiated by a group of scientists in Barcelona. There is a very famous Alzheimer's scientific community in Barcelona, and Barcelona is also the home of a company called Grifols, which is a family-owned company. It's a biomedical company. They are involved in the production of albumin and other medications that are made from human plasma. So the idea behind the study was that, as you and your audience probably know, the still remaining cause of, or our belief that the cause of Alzheimer's disease is amyloid. Amyloid is a protein that circulates in the blood and gets deposited in the brain and causes damage. There are arguments against that, but so far that's the predominant theory for Alzheimer's disease. And I'll show you in a little bit that that's not exactly true, but to a certain extent, it is true. So the Grifols people said, well, we make albumin, and albumin is a very important part of the plasma. It's the most significant protein in the plasma. And the albumin the molecule of the albumin has multiple receptors on its side. And it has been shown in vitro that these receptors attract amyloid. So their idea was, if we overwhelm the blood system with albumin, it will bind amyloid and will prevent it from accumulating in the blood, in the brain. So that was the idea behind that. So in order to do that, they had to do plasma exchange, because otherwise they will overwhelm the body with fluid. So they're going to remove the old plasma and substitute it with the human albumin that they make. And everything today, and probably in the past as well, is done because of money. They want to sell their product. So they decided that their product's going to predominate here. And to their credit, they funded generously a very serious clinical experiment that involved placebo-controlled clinical trial. 400 people divided in different groups, and performed plasma exchange in Barcelona, as well as in different places in the United States. My my staff and I, we were in charge of the procedures in the United States. So the results were pretty good. We were able to arrest the progression of the disease in moderately severe Alzheimer's disease in 67% of patients. At that time, this was unheard of. It was great. In the mild Alzheimer's disease, we saw significant improvement in cognitive function, memory, and everyday life. So the study was pretty successful, and it was published. Unfortunately, it was published in 2021, right in the midst of the pandemic. So I didn't get as much attention as it deserved because the attention was someplace else. And in the meantime, there were two monoclonal antibodies that were approved by the FDA, despite the advice of their advisory committee not to approve them because the evidence was insignificant. And I'll show you how this thing works.
You should be able to share.
Yeah, I'm working on it.
Okay, there you go. We can see your screen.
Okay. Let's see here. So this slide shows the comparison between the two monoclonal antibodies. This is one, this is the other. They went on market approximately 1 year apart from each other. And these are the scales, the different functions of Alzheimer's disease that we measure. And these are the results from the monoclonal antibodies. And these are the results of the AMBER study. The study that we did was called AMBER study. And as you can see here, the success rate was 18, 40, and 37% with the monoclonal antibodies and 52% in the AMBER study. In the other tests, 11, 27, and 26 versus 66%. And in the third parameter, 2%, 22%, 27%, 71%. And these
So wait, sorry, can I just stop you there for a second
Yeah.
just to explain to people what this actually means? So the ADLs and the COG these are scores, is that right? Are you talking about the scores for the COG? So they were performing 66% better, is that correct? Than the baseline? Is that what that means?
Right.
Okay. And then the ADL, explain to people what that means exactly.
Well, these are different tests that are done for cognition of Alzheimer's.
Okay, so all three of them are different types of
all
tests.
the different there.
Okay,
So
got it.
yeah. So the AMBER study outperformed all of those. In addition to that, the monoclonal antibodies attack the amyloid plaques in the brain, and if they're successful at killing them, this causes a dramatic change in the brain, including edema, infarct, and so forth, and causes horrible side effects. Some people have developed suicidal thoughts, some people have died, some people have had strokes, and so forth. So these events are pretty common, 40% in the two of the monoclonal antibodies. The newest one has little less. But just the fact that these serious side effects do exist pretty much limits their use because people are afraid to take them. And in our case, we had 0 side effects of this nature. This here also shows that the pathophysiology of Alzheimer's disease is not only related to amyloid, but it's related to other systems as well. So one is genetic, obviously. The other one is the immune system, is inflammation, infection. P-tau is another protein that is deposited in the brain abnormally. It's related to infection, to nutrition, and so forth. So the etiology of Alzheimer's disease is very complex. So it's highly unlikely that a single monoclonal antibody, and I don't know if people know what this is, but monoclonal antibodies were designed to attack a single molecule or a part of molecule in the body. So attacking a part of molecule in the body is highly unlikely to affect all these different things that are involved in the cause of the disease.
Okay, so let's take this back to the plasma exchange because I'm fascinated by that. So in the AMBER study, you basically had placebo versus non-placebo, and they were given transfusions of plasma that gave them more albumin. Is that albumin? Is that correct? Which is a good protein?
Yes.
Okay.
Albumin, we use 5% albumin in saline. So
So do you actually physically have to take all the blood out? Like, how does that work? I know it enters a machine that spins out the platelets and the, plasma, but how does it work to what does plasma exchange actually mean to the patient? How long does it take? Do you have to get the blood out and enter new blood, or what is it all?
Plasma exchange, or TPE, refers to a specialized medical procedure in which blood separation technology is used to remove abnormal plasma constituents. Whole blood is removed from the patient into a blood cell separator, which utilizes centrifugal forces to separate whole blood into its individual components: plasma, platelets, white blood cells, and red blood cells. Plasma can be removed and replaced with physiologic fluids to treat relatively uncommon but usually life-threatening diseases.
Did this help?
Yes. Okay. So we've just seen that video on what actually happens, but tell me what happened in the Alzheimer's patient. You saw a reduction of plaque. Okay. So I think you involved early to mid-stage patients. Is that correct? Of Alzheimer's.
Correct.
Okay. So tell me what you saw.
No, mid or early stage. Yes, that's correct.
Yeah, early to stage. So tell me, so obviously all of these patients had beta amyloid plaque conformation, right? They were plaque positive.
Correct.
So did the plasma exchange take the plaque away? What happened? What was the outcome?
Right. So the MRI studies have not been published yet. I know it's been several years, but it takes time to do the evaluation. So I don't have the answer to the plaques per se. It is very difficult to evaluate the number of plaques and the volume of plaques, and then calculate how this was diminished. There are new tests now that are much more accurate and better for diagnosis and research than the tests that were available to us at that time, 6 years ago. So this data is not available, not to me, not to anybody yet. It is still being evaluated. The amount of the amyloid in the blood was calculated. It was definitely diminished. So the idea was that if you diminish the amyloid in the blood, you will reduce the accumulation of plaques. Whether we remove the plaques from the brain, we don't know that yet.
So have these patients, are they constantly being followed up? Do we know if progression, I mean, because with the monoclonal antibody therapies, we obviously know, some people believe that it does delay, but it's pretty insignificant at the end of the day, right? It's just the first part of an equation that's being trying to be solved. So do we know in terms of how much I mean, you have the measure of the cognitive assessments. Are those cognitive assessments still going on? How many times do you need this procedure? Is it just once in a lifetime, or is it continuous? I guess a lot of these answers aren't known yet, but tell us as much as you can in terms of what this means to the patient.
Right. Well, that's very important. The initial study involved 6 treatments within a short period of time. And when I say short period of time, it was about a month. So 6 treatments almost once a week.
So wait, Dobri, do you want to just take sharing off so we can go back to the video? I think it's better if you could stop
Yeah.
sharing.
Okay.
Thank you. Okay, sorry. Go ahead.
I wanted to show some other stuff, but maybe.
Oh, okay. Okay.
Okay, doesn't matter. Let's
Okay, you can
answer
put it.
the
Thanks.
question. So we performed 6 procedures within a month, and then we followed that with monthly procedures for another 6 treatments. So overall, they got 12 procedures. Is that enough? The answer is no, because Alzheimer's disease is a chronic disease. The treatments available today, both ours and others, are going to be chronic treatments. They're not curative. We don't cure anybody with whatever we do so far. The other thing that is really very important is that what we do is not only curative, but it is also preventive. And today we have the tests to identify the population that is at high risk for Alzheimer's disease through genetic testing, through other parameters that are available to us now. And these are just over the last several years. So we can identify people who have genetic predisposition or just the beginning of the disease at an early stage. Because people with genetic predisposition will develop the disease much earlier than usual. The usual Alzheimer patient is 80 years old. And these people get the disease very early, in their 40s, in their 50s, which is very unusual for typical Alzheimer's disease. I'm treating two sisters who lost their parents at age 50, both of them. And they're at very high risk for developing the disease. So we treat them periodically to prevent them to develop the disease.
So they're getting the plasma exchange treatment.
Correct. Yes.
Okay. So this is FDA approved everything. Like this is a known way of, is it FDA approved, this technique?
Yes.
Yes.
Yeah.
Okay.
Therapeutic Plasma Exchange is FDA approved. The FDA basically approves the machines that we use, and we as physicians can use the procedure for whatever reason we need it.
You want to. So
Yeah.
what is, I mean, there has to be risk tell us what some of the risk is associated with this type of treatment.
Well, let's bring back the this is a study that I did that evaluates the adverse reactions of therapeutic plasma exchange that is published in the literature from major hospitals around the world, from France to Sweden to Japan to the United States and so forth. And you can see these are the blue lines indicate the percentage of side effects that people see. And these are the authors of the articles. As you can see, it varies dramatically. These guys have very high adverse reactions. These have less. And Dr. Kaplan and myself have much less. And the AMBER study has about 10%. The red ones are the ones where people used fresh frozen plasma rather than the albumin that we use. Fresh frozen plasma is much more dangerous in terms of side effects and even death. So it very much depends where the procedures are performed and who is doing them. People who are well trained and know what they're doing will have a very small amount of side effects. Actually, in our experience, in the last study we did, we had less than 1%. We had only one side effects in more than 300 procedures. So if the procedure is performed by experienced people in the correct environment, the side effects will be minimal.
What are the side effects?
The side effects can vary. They are usually related to the vascular access. So there is the unpleasant experience of starting IVs. The IVs can leak, they can cause hematoma, they can cause some bleeding, they can cause infection. Some people, we don't use that in an outpatient facilities, but some people use central lines because the peripheral veins are inadequate. And the central lines are associated with infections, pneumothorax, which is accumulation of air in the lungs, and stuff like that. So yes, there's some of the side effects can be serious. Minor side effects include tingling of the fingers and around the mouth, and hypotension, drop of blood pressure. These are more common, but in our experience, we do not allow any side effects to happen. We prevent them. And the key in good medicine is prevention rather than treatment.
So just to kind of sum this up, because we're running short on time, but you would think of this more as an effective preventative treatment for inflammatory. I mean, it's not only Alzheimer's disease, but you're talking about other inflammatory diseases that can become chronic. So is the trick to really use this as a preventative treatment before, or like early on, like very early stage symptoms, or where do you see it tying in?
The answer is yes. In any medical situation, the earlier you start, the better. Your chances of succeeding, if you start early, are 100 times better than if you start late. And this can be the flu, it can be cancer.
Right. So can you stop sharing again? Sorry about that. I just want to be able to see you and not the screen. Thank you. So what would you say? I guess the next question I have is, and I'm sure on people's mind, is you've addressed side effects, and I'm assuming, because this is maybe a more preventative technique, that it's very expensive. And is it covered by insurance?
For certain diseases, it is covered, but it has to be done in a hospital setting at the moment. What we do is we treat patients on an outpatient setting for a variety of reasons. First of all, they don't have to wait in line to get in the hospital. It's considerably less expensive to get in the hospital. Just your first step in the hospital is 10 grand before you start getting treatments. So we can offer the treatment considerably less expensive. It is still expensive for most people, but we can offer it much less than the hospital can offer it, and in a much more pleasant environment that is more acceptable to patients, and they feel good coming here. They want to come. Unfortunately, it is not readily reimbursable by insurance companies. We are working on solution for that. It's going to take time. Everything with insurance companies takes time. And also the number of procedures, it's an economy of scale. The more procedures we do, the less expensive it's going to get. And slowly we're going to get there, but we're not there yet now.
And last thing, where does the plasma come from? Like, how do you get the plasma, and how long does each treatment take?
2 hours.
It takes 2 hours, and you're hooked up to a machine, but where does the plasma come from?
Okay, so there's a confusion. Although it's called plasma exchange, we do not use plasma to replace the plasma that we remove. We use 5% albumin, which is a pharmaceutical product. It originates from donated plasma, but the way it's manufactured and manipulated with heat and other methods, it doesn't resemble plasma at all, but it contains the major protein of plasma, which is protein albumin. So we use 5% albumin in salt water.
Okay, this is fascinating. Well, Dobri Kiprov, thank you so much for sharing. Where can I think you have a website people can learn more. We'll post the link to your website and which has some of your studies included. There's also a great YouTube video out there that we can also post the link to, where Dobri explains how they came to this and some of the research going forward. So thank you so much for taking the time to share with us.
You're very welcome.
If you missed any of this interview and want to learn more, go to beingpatient.com and sign up for our newsletter, because that's where you will have notice of talks like this one. So thank you so much to Dr. Dobri Kiprov. Keep us updated on all of your research. We're especially interested in the Alzheimer's. So please let us know when you learn more, but thank you for sharing.
Sure.
Okay, take care.